My name is Laura Hummers. I am a rheumatologist, and I've been working in the scleroderma field since 2000, so about 18 years now. And I co-direct the Scleroderma Center at Johns Hopkins along with Frederick Wigley. And today we are going to talk about understanding what link there may be between scleroderma and cancer. I tell my patients, if life were fair and you have scleroderma, you shouldn't have to worry or think about any other health issue at all. But as we know, life is not fair, but what we do know, we are kind of piecing together this connection better. And while for the vast majority of patients, cancer is not something that we think might be connected, we do think that there are subsets of patients where there is a connection. So we're going to kind of walk through that today. I'm going to ask, because this session is being videotaped, which is great, so anybody who isn't able to attend today who wanted to see it will be able to get it afterwards on the website. But because of that, they want us to hold questions until the end. So if we could just do that. Thank you. Okay, so what we'd like to talk about today is review what's known about cancer risk in scleroderma, and talk about kind of both the magnitude of what that risk is, and then we'll talk about timing a little bit because we think that's important. So this idea of temporal clustering. So we actually learned what we know about the connection between scleroderma and cancer because of observations where people were getting scleroderma and cancer very close in time, and that mechanistically made us think that maybe there's something connected there. And so we'll discuss reasons there may be a connection, because it's actually not so obvious how they are connected. There's actually probably multiple ways they might be connected. And then I'm going to show you some new data that came out of our center that focuses on data about what we know about the kind of scleroderma that you have, what skin type you have, what antibodies you make, and how that might impact your risk for cancer, because we actually learned some very important things with that data. And actually found some unexpected things as well. And then we'll at the end talk about what this information means about how we should think about screening for cancer in our patients with scleroderma, and implications on, if you had cancer and scleroderma together, what that might mean for treating either one, what the implications are for treating your scleroderma if you have a history of cancer, and vice versa. If you have scleroderma, what implications that might have in treating the scleroderma. Okay, so I'm going to present a very quick patient scenario, because this is actually how our center got interested in studying this connection, because we observed cases like this patient's scenario. So this is a patient who is a 43-year-old female smoker who developed Raynaud's phenomenon in 2006, and she had some swelling in her hands and face. And as they were working up trying to figure out why her hands were swelling, she had some chest imaging done and was found to have a small cell lung cancer as part of that workup. Before she was diagnosed as having scleroderma, she underwent treatment with chemotherapy, radiation, and some brain radiation as a preventative. But in that next year, she developed more signs and symptoms that pointed in the direction of scleroderma. Her Raynaud's got worse, her hands became more swollen. She developed now new diffuse skin thickening involving most of her body. And actually the thickening was worse in the port where she'd had radiation. So she had had radiation to the chest, and the skin tightness was worse there in the top of the chest and the top of the back. And so when she presented for her Scleroderma Center assessment, there was a clear question here. These two events came very close in time, the diagnosis of her cancer and the diagnosis of her scleroderma. And so the question was, is there a connection? And there, again, might be multiple reasons why there might be a connection. So the question is this something related to scleroderma? Having, for example, fibrosis in your lungs, does that put you at risk for getting cancer? Does that damage in the tissue change your risk for getting a lung cancer in particular? We know that radiation causes scar tissue formation. Could somehow the radiation treatment that she got for the lung cancer, could that have triggered this scleroderma process to get worse? Or is it possible that the immune system got activated trying to fight off the cancer, and then scleroderma developed as a result of that? And I'm just going to point out that this patient, because we're going to talk about this a few different times, makes an antibody called anti-RNA polymerase 3, which is one of the scleroderma-specific autoantibodies, and we'll go through why that's important. So just to step aside for a second and make sure we're all on the same page with regard to scleroderma antibodies, there are very specific antibodies that are related to scleroderma, and in scleroderma, usually patients will make one of these scleroderma-related antibodies. So the test that maybe you've all heard of is the ANA test, which is kind of like the screening test for making an anti-nuclear antibody or an autoimmune-related antibody. But these very specific antibodies, including RNA polymerase 3, which is this one down here, and SCL70 and Centromere, those are the three most common autoantibodies in scleroderma. And not only are they very specific to scleroderma, meaning patients with other rheumatic diseases typically don't make these antibodies, is that knowing which antibody a patient makes can actually tell you something about what might happen as part of the scleroderma. So for example, the SCL70 antibody associates much more strongly with lung fibrosis than the other antibodies. And patients who make RNA polymerase 3 tend to have more significant skin thickness involving more areas of their body, and a higher risk of kidney involvement than patients who are in other antibody groups. And then if you look at the breakdown, I don't know if those colors project very well, but Centromere, SCL70, and RNA polymerase 3 autoantibodies are the three most frequent antibodies that we see in scleroderma and represent, almost 3/4 of patients, whereas other patients make less frequent antibodies, or sometimes there's a small set of patients where we can't identify the antibody that they're making. And we do know that because of what happens to people in these different antibody groups, that may actually have impact long term, and survival might be different depending on antibody subsets. So just because we're going to talk about this antibody in particular, RNA polymerase 3, a couple of times, I'm just going to explain what we know about patients who make this antibody. They tend to have this very explosive onset of skin tightness. So they get swelling in their hands and feet, and then almost always this progresses to skin tightness everywhere. Their Raynaud's may actually develop after other symptoms, whereas in almost every other patient group that we know about, Raynaud's is the first thing to develop. That's why sometimes this gets confusing. When the swelling happens and the patient doesn't have Raynaud's, that the scleroderma doesn't get diagnosed actually necessarily right away. They're at higher risk for scleroderma kidney disease than any other subset of patients, and about 1/3 of patients might develop scleroderma kidney disease. So in patients where we identify this antibody, at least in our center, we put them on a very strict regimen of watching blood pressure to look for signs of this kidney problem. There is an association with muscle disease, an association with a condition called GAVE, or watermelon stomach, which can cause bleeding from the stomach and can cause anemia in patients who have this antibody. And we can order this test now. This used to be very difficult to access this test, and now this is more widely available. So almost everybody now, all your rheumatologists should be able to order this test. So just to summarize antibodies, they're unique to scleroderma for the most part. Typically, patients make one antibody. So we actually have cousin diseases to scleroderma, like lupus, where it's very characteristic that they'll make 2, 3, 4 antibodies. Scleroderma patients, we consider these antibodies for the most part to be mutually exclusive. So you make one and usually not the others. Not all patients make a known antibody, and antibody associates very strongly with the kind of scleroderma that you have. So it does really help us when we meet somebody for the first time to say, okay, your disease started at this point in time, and I know you make this antibody. That actually really helps me know what we need to think about going forward. So let's take a step back now to cancer again. So again, the questions are, did scleroderma lead to cancer? Fibrosis happened, damage happened, that led to cells becoming cancerous. Did cancer treatment lead to scleroderma? Did cancer, the opposite direction, did cancer lead to scleroderma? And then what do we need to think about, again, treatment of each because of the presence of cancer. In this patient's situation that I presented, she needed treatment both for her cancer and for her scleroderma because she had very rapid skin disease, and there's actually implications for treating each of those depending on having the other diagnosis. And then the bigger question for us is, when somebody comes in new to us, is there something about this patient and their scleroderma that might tell us who we need to be more vigilant for looking for cancer? So we're going to go through that. So just to talk about how many patients we're talking about, I certainly don't want anybody to leave this room and think, oh my God, everybody with scleroderma gets cancer. That would be terrible to have you think that, and it's totally incorrect. So there's about 300,000 people in the US who have scleroderma, but if you look at the subset of people who have systemic disease, meaning you take out the patients who have morphia or localized skin versions of scleroderma, there's maybe about 100,000 patients in the US with systemic sclerosis or systemic scleroderma, and only about 12% of patients have cancer. But malignancy accounts for somewhere between 7 to 17% of all deaths in scleroderma patients. And so if you look and you compare this to, and we'll go through some of this data from general populations, the risk is a little bit higher among scleroderma patients. Not dramatically higher, a little bit higher than the general population. And so I might use a couple of terms that I just want to explain really quickly. So when we talk about relative risk, we're talking about risk comparing two different populations. So if 10% of patients with scleroderma get cancer and 1% of the general population gets cancer, that is a relative risk of 10. And then we have some data that looks at what's called standardized incidence ratios. That's how many cases of cancer develop over a particular period of time. And if, again, 10 patients per year develop it in our population that we're interested in, which is scleroderma, and one case in the general population, that relates to what's called an SIR of 10. This is just to help try to make sense of some of the numbers that we'll look at. This usually, particularly when you're talking about relative risk, sometimes you'll see these relative risk numbers that are very high. Oh, the risk of having this kind of cancer is 10 times higher in scleroderma. And you're like, oh my God, I'm going to develop this kind of cancer. If you look at how often that cancer happens in the general population, if it only happens to like 0.001% of patients, then we're talking about it happening to 0.01% of patients in scleroderma. We're still talking about an overall very small risk. It's just that the difference between the two populations is different, which is important for us from a research standpoint to try and understand this connection. So about 10 years ago, there had been a handful of studies trying to look at this risk and say, well, how high is the risk in scleroderma compared to general population estimates of risk? And pretty consistently, these studies have suggested that the risk of cancer is maybe about 2 times higher than it is in the general population. And around the same time, too, there were cases being published where cancer and scleroderma were happening close in time together. And again, that made people start to think that there might be a connection. But there were also case reports of scleroderma improving significantly when cancer was treated. And there's probably a couple different reasons why that might happen. One, that some cancer treatments might treat scleroderma, like Cytoxan, for example, is a drug that gets used to treat cancer and scleroderma. Or it may be that when you eliminate cancer, and if that was what's driving the scleroderma, then maybe that's why the treatment is effective for scleroderma. So all these things were kind of leading us to say, we really need to do some more work to try and understand this connection. And these are just a few examples of cases that were reported in the literature where somebody who had different types of cancer and scleroderma happening at the same time. For example, the first case, somebody developed scleroderma, diffuse kind of skin disease, and lymphoma at the same time, and their scleroderma improved dramatically when they were treated with chemotherapy. Same thing in this case with scleroderma, again, diffuse kind of skin disease and leukemia. Their scleroderma, skin disease, improved just when they got chemotherapy. Same thing with this case with multiple myeloma. So again, an intriguing observation that helped us frame some of the questions. So now, more recently, we have kind of better estimates of this risk. So in 2013, this group presented data where they put 16 studies together with 7,000 patients and looked at risk compared to the general population. And again, there was about in this study 1.75 relative risk, meaning 1.75 times higher in scleroderma compared to the general population. And they noticed that certain types of cancer, that risk might be higher. Again, the overall risk is still pretty low, but when comparing risk to the general population, it seemed to be higher in scleroderma. And there were a few more uncommon cancers that still seemed to be increased, but the numbers were smaller and hard to make that association. But these studies have limitations, these epidemiologic studies. So these didn't account for very important things that we know are related to cancer, right? Like smoking and medication exposures, what kind of scleroderma somebody has, which we think might be important, and what kind of underlying trouble they had for their scleroderma. Because again, if potentially scleroderma tissue damage might lead to cancer, potentially we'd kind of need to know that to really appropriately assess the risk. So this, again, suggested that the risk overall is a little bit higher, but didn't answer all the questions that we want answered as rheumatologists. There was a second study that did a very similar kind of analysis, and this looked at the standardized incidence ratio. So this was 1.41, again, comparing the number of cancers that develop over a period of time in scleroderma compared to the general population. And this study suggested some increase in a few different types of cancers as well, including lung, bladder, blood cancer, liver, and skin cancer. And maybe this risk was overall increased in men. This study did look at timing, and the risk in the 12 months before, in the 12 months after scleroderma diagnosis was higher, almost 3, than in the 12 months after diagnosis, where this number was actually closer to 1. So this is the first study that really looked at this timing issue to say if it was important. And yes, it seemed that cancer and scleroderma were occurring together, and that risk seemed to be increased in that period of time right around the scleroderma diagnosis, and maybe not so much later down the road. And this study did look at smoking and lung fibrosis, two things that we think are important to at least understand the risk from a lung cancer standpoint, and didn't really find a difference. So it seems that the risk of lung cancer and blood cancers might be a little bit increased, and that liver, esophagus, some types of skin cancers, and bladder cancers may be as well. There was no excess breast cancer risk in these studies, but it's still the most common cancer that we see amongst our patients. Most of our patients obviously being women and developing scleroderma, usually in 40s or 50s on average. And the risk might be higher in men. Patients who are older when they develop scleroderma, those with certain drug exposures, and maybe with more severe damage from their scleroderma, but clearly this risk seemed to be higher in the year after diagnosis. So there are still some questions that we didn't know more detail about. Again, what type of scleroderma somebody has might influence the risk. What age somebody develops scleroderma might influence the risk. What medications they used for their scleroderma, which may influence the risk. And some of their disease-associated manifestations of their scleroderma, like if they have lung disease or reflux, might put them at risk for certain types of cancers. We won't walk through all of this in detail, but in terms of hypothesizing ways that there might be connected, we talked about some of these already. Is it possible that treatments for cancer could lead to scleroderma? And there are certainly aspects of scleroderma that could certainly be worsened by these treatments. And the question is, could it really induce scleroderma to begin with? So there are some types of chemotherapy which are associated with a very severe Raynaud's phenomenon. And radiation, as I mentioned, can cause more severe fibrosis sometimes in a small subset of patients. So the question is a process like that triggering scleroderma? And we don't really have great data to suggest that that's true, although we do know that these things do infrequently happen. We don't have great data to show that it actually causes scleroderma. It is possible that there's some sort of shared genetic susceptibility, that people might be predisposed to both cancer and scleroderma, and we do have some patients who have family trees where there seems to be autoimmunity and cancer kind of scattered through a family. This has not really yet been very much explored. It's possible that there's some common inciting exposure, that you get some exposure to something and that it predisposes to autoimmunity and cancer. Again, we don't have data yet to suggest that that's true, although we know there are some exposures that are infrequent that can be related to cancer development, like scleroderma development, like silica dust exposure in minors, for example. And then the question is, could there be what's called paraneoplastic scleroderma? So does the tumor response that you make to cancer leading to the production of an autoimmune disease? And that's the aspect of this that there's been the most data on so far, looking at that possible connection. So when this was looked at by Ami Shah in our center, we have a fairly large scleroderma database with over 3,000 patients. Actually, now it's about 3,700 patients in it. And we looked at the cancer in that population. And as we mentioned before, breast is the most common cancer. Of all the patients who had cancer in our group, a third of them had breast cancer, followed by lung and skin cancer as the most common after that. But these are cancers that are, again, common in the general population, so there didn't seem to be necessarily anything different about the distribution of cancer amongst our patients. But when we looked at when cancer developed relative to when scleroderma developed, and if we look at this line here, this is within the same year, we saw this kind of spike of amongst the patients with scleroderma and cancer. If you had cancer, it was more likely that they were going to occur at the same time. So this spike here suggests, again, 0 meaning they occurred exactly at the same time. To this side, it's the cancer predated scleroderma, and this side, cancer came after scleroderma. There seemed to be this kind of peak here in the middle. And of the patients with cancer and scleroderma, about 22% of them were in this window. And then, so what was done next was we said, well, does it matter what kind of scleroderma you have, and particularly which antibody you make, in terms of when that interval might happen if you have cancer and scleroderma together? So this line going this way, this is cancer and scleroderma happening at the exact same time. And so patients who made this RNA polymerase III antibody, if they had cancer and scleroderma together, almost all of them happened in this very tight window of cancer and scleroderma happening together. Whereas patients who made other antibodies, like SCL70 or Centromere antibodies, if they had cancer and scleroderma both, they didn't seem to occur that close to each other. You know, this was more than 10 years apart for both of these. So, and not very many patients had cancer and scleroderma happening together if they had both. So this made us think that, you know, if there's a connection, we should probably look in this group, because this, from a mechanistic standpoint, looking where these two events happen together might make the most sense to start looking at that group. And when we looked at risk amongst our patients with scleroderma with cancer, those who made this antibody had about a 5-fold increased risk of cancer within 2 years of scleroderma happening compared to other scleroderma patients. Now, this is not compared to the general population. This was compared to other scleroderma patients. So it's made sense to kind of focus here. And so when our collaborators in the lab started looking at this, they asked our patients who had both scleroderma and cancer if they would allow us to access tissue from their cancer specimens to be able to look at this in the lab. And I don't expect you to know what these cells are or what these stainings mean, but all I can tell you is that when cancer specimens from patients with scleroderma who made RNA polymerase III antibodies were examined, they saw what's called increased expression of this protein in their tumors. and that we know that their blood reacts both to the cancer RNA polymerase III and to kind of normal RNA polymerase III. So what does that mean? So conceptually what this means in terms of how that connection might happen is we're making cancer cells all the time, all of us. The cell processes go awry, you make a cancer cell. And the vast majority of the time, your immune system recognizes that and says, oh, this is different, we don't like this, we're going to get rid of this. So you make an immune response against these kind of mutated cells. So normal cells get transformed into cancer cells. You generate antibodies against these tumor proteins, and the majority of the time you eliminate these cells, you don't get cancer, life is good. But what this data suggests, looking at this protein expression in these cancers, is that maybe now, in the process of trying to fight off these cancer cells, now you're making an immune response that is now autoreactive, that is now autoimmune. And now you're making antibodies to not just these mutated proteins that are in tumors, but actually just the regular protein. And now this might translate into a problem in normal tissues, not just cancer tissues. So that's how these two things might be connected. So what are the possibilities? You make this immune response against these tumor cells, and most of the time, what's supposed to happen is you control cancer. You don't get autoimmune disease, you get rid of the cancer cells, everything is good. Sometimes you can't fully get rid of the cancer cells and you develop cancer. And then sometimes the end result could be, well, you effectively fought off the cancer, but now you're left with this autoimmune process. And sometimes both could happen, that you can't the immune system doesn't fully get rid of the cancer, and you have this byproduct of this autoimmune process. And it's this group of patients really that we really have the opportunity to study in terms of trying to understand that connection. If there are patients who are controlling their cancer and had scleroderma as a byproduct of that, we don't know because they've controlled their cancer and the cancer is gone. So the conclusion from these studies were that there is this very close timing between cancer and scleroderma, and that's very particular amongst a group of patients who make RNA polymerase III antibodies. In that subset, RNA polymerase III protein expression is seen in the cancer cells, and it suggests that tumor and antibody response at least are associated. Now, what we don't know, and this is true in scleroderma in general, is that we don't know that those antibodies are actually what's causing trouble. We just know that they're very specific to scleroderma and they're part of the autoimmune process of scleroderma. We don't know that RNA polymerase III antibodies or any of the antibodies are going around directly leading to skin thickening or esophageal problems. So we don't know that. But there does seem to be this connection. And this is just another picture when we look over time and see the age in which people develop cancer and the age in which people develop scleroderma amongst these antibodies. As you can see in this antibody group, the age of scleroderma onset was a first peak and then cancer came later. This is now kind of after the age of 60 to 80 was when the cancer peak happened. Whereas in those with RNA polymerase III, this peak happened almost entirely overlapping. Interestingly, some of these other antibody groups may suggest that age might be related. So if you look at this RNA polymerase III line, this is again them coming the exact same time. They're all clustered right around this line. But if you look at some of these other groups, as patients get older, maybe there is some more clustering around this line. And this kind of suggested to us there might be age might be playing a role. And we did find in some of our studies that the age in which somebody develops scleroderma might be a risk for, might be associated with an increased risk of cancer. But for some antibodies like RNA polymerase III, age doesn't seem to matter as much. And this study also suggested that other antibodies might have a risk similar to RNA polymerase III, but not our more common antibodies that we look at. And there's more work to be done there. So the age at which somebody develops scleroderma might have something to do with the risk. And when people say, well, we know, we all know our risk of cancer increases as we get older, but this isn't just age. This is the age at which somebody develops scleroderma that might be important. So this led us to a more recent study, again performed by Dr. Shah in our group, and Dr. Takagusa, who did a lot of the computational work in this study. So the question to us as rheumatologists is, again, if I see a patient who's coming to us new, I want to know, do I need to be more vigilant for cancer screening for a new patient coming in the door? So in this study, we looked at cancer compared to the general population, and there's this nationwide registry in the United States called the SEER registry, which collects data on cancer across the entire United States and can give very good detailed background risk information about particular types of cancer and at which age they develop and in what gender, and in particular races and ethnicities. So we could look at our scleroderma patients and compare it to this registry of the general population. And we can adjust for age and sex and race and ethnicity and calendar year, meaning what year our patients are developing scleroderma and cancer. And this allowed us, because we have very detailed information about our scleroderma patients, to look, is the risk increased overall compared to the general population, but also look at very specific cancer risk. And what we really wanted to do for our standpoint is to see, did that risk differ compared to the general population depending on which antibody you make, what kind of skin disease you have, and again, this issue about timing in terms of when cancer happens and when scleroderma happens. So I'm going to walk through this. So this is numbers of cancers now divided by what kind of antibody you make compared to the general population. So actually, if you look at, this is the all line, and they're pretty actually close together for the most part. So this is the RNA polymerase III antibody. So blue is scleroderma, and this is numbers. So as you can see, this line has this kind of very big spike, and this 0 time point is timed from the age at which somebody develops scleroderma. There still seems to be this very big spike very early on. So this is numbers of cancers compared to what would be expected in the general population. So it confirmed kind of what we had thought about before in terms of RNA polymerase III. I had mentioned before, we think there are other antibodies where this risk might be increased early. And these are people who don't make these 3 antibodies. There probably are small subsets in here that might be at increased risk as well, but we don't know as much about these antibodies. Topoisomerase, one of the 3 most common antibodies, did not really seem to have a big difference between the general population in terms of numbers of cancers. This is the one that completely took us by surprise. People who make the anti-Centromere antibody over the entire course of this time frame, so this is 18 years from the time scleroderma develops, this is the risk, the number of cancers in the general population. This is the number of cancers in the scleroderma patients who make centromere antibodies. It is very consistently lower than the general population. So even though the overall risk of cancer at scleroderma compared to the general population is a little bit higher, it is probably a mix of groups of some patients having this increased risk, but other patients having this decreased risk. Which is why maybe this was hard to sort out at the beginning to try and figure this out. And we could go into all kinds of reasons why this might be true. One of the more obvious explanations is maybe people who make this antibody have a very effective anti-tumor response. And there is something about this antibody that means that they're much more likely to control their cancer, but we don't know that. And this is just looking at the same thing in a slightly different way. This is from, again, years from when scleroderma develops. So this peak is high in this RNA polymerase III group, but remains higher. So now this is kind of not numbers, but risk, higher compared to the general population. And again, centromere antibody, these are the scleroderma patients, always staying below this number of expected cancers with this kind of, we call it a negative risk, the risk being lower than in the general population. So this was kind of totally unexpected findings. Interestingly, now, because we had the opportunity in this data set to look at particular tumor types to say, well, does antibody influence, or is that risk in particular cancers still there? Centromere antibody still stays a little bit lower than the general population, but not as dramatic here. But RNA polymerase III, again, and closer to the time of scleroderma diagnosis, still seems to be elevated in this population.
Question?
Yes?
The top chart on the poly 3, looks like at 12 years it flip-flops, yet the bottom chart doesn't present the same.
Yes, sorry, this is, so the question is, why is there a difference between the top part of the graph and the top of this graph and the bottom? This is actual numbers of cases, so that's the actual numbers of patients per year, whereas this is what's called a hazard ratio, so it's a risk difference. So in terms of looking at cancer risk, and particularly looking around this window of when scleroderma develops, this data suggested a few things to us, that diffuse scleroderma patients have a little bit higher risk overall, but anti-POL3 antibodies have a much higher risk compared to the rates in the general population, what is expected. And in our diffuse skin patients who have more skin tightness, breast, prostate, and interestingly, tongue cancer, seem to be much higher risk compared to rates in the general population. And amongst our limited patients with POL3 antibodies, lung cancer seem to be at high risk. Now again, you see this and you say, oh my God, a standardized incidence ratio of 44 in tongue. The risk in the general population of tongue cancer is like this big. So this number could be really big, and the overall risk is, for an individual patient, is still quite low. But this does teach us something about, why these cancers in particular. And then again, this centromere antibody thing was found in all cancers together, was found in breast cancer when it was looked at specifically, and there was a borderline association with lung. So this seemed to be a fairly consistent finding that centromere antibody patients seem to have a lower risk of cancer. So patients with RNA polymerase III antibodies are high risk for cancer compared to the general population. Cancer risk might vary depending on what skin type you have, where our diffuse POL3 patients had more breast cancer and our limited POL3 patients had more lung cancer. And patients with centromere antibody have a lower risk of cancer compared to the general population. Again, totally unexpected finding. So what does this mean in terms of cancer screening? So I can tell you how we approach cancer screening in our patients. This is not based on the ideal data. Ideally, we'd have a screening regimen and we'd study it going forward, and we'd show that this actually helped in terms of making cancer diagnosis at a better time or leading to better treatment. But this is kind of what makes sense to us now based on all this data that I just showed you. So when we see a new patient with scleroderma, we think about cancer every time and say, is this something I need to think about or not? So every person gets a full exam in our center anyway when we first diagnose scleroderma, which would include skin everywhere, lymph nodes, thyroid gland, everything else. And then we kind of think about age-appropriate screening. So colonoscopy for those 50 and older. And there are some screening recommendations. So they don't recommend colonoscopies now past the age of 75 for the general population. But again, if age has something to do with the risk when somebody develops scleroderma, I would certainly think about it in that scenario. Whereas you wouldn't think of that necessarily in the general population. And then we talk about smoking cessation and sunscreen with everybody, so those are two modifiable risk factors for everybody for cancer. And then when we think about gender-specific screening, screening mammogram at diagnosis and annually if 40 or over. If you read all the different recommendations for cancer screening coming from different places, you know, it's controversial between 40 and 50 if you need to do annual mammography. It kind of just makes sense to us because of what we'd seen with breast cancer risk, that if you're going to err on the side of caution, that you would probably start at 40 and not 50. Pap smears every 3 years between 21 and 65. And then Pap and new onset of scleroderma, even if you're over the age of 65, just to make sure. All women should have a gynecologic examination. And if somebody is high risk just from a cancer standpoint, meaning they have breast or ovarian cancer in their family, or they're known to have some of the cancer-related genes like BRCA gene, then we probably should do some additional screening. This is what would be done in the general population anyway. And then in men, getting PSAs checked, and if you're younger than 40, getting a testicular exam. This is kind of general population recommendations for screening for cancer. And then we have to think about particular risk factors and particular screening for cancer. So I don't know if you know, but now there's new screening recommendations amongst smokers for screening for lung cancer. This isn't if somebody develops symptoms or has something happen. This is for everybody who has a certain amount of smoking exposure and getting low-dose CT scan annually if you've had a significant smoking exposure. And we, from the scleroderma side, always want to get a baseline CT scan of the chest when somebody is newly diagnosed with scleroderma to help us look for lung disease. We don't know how often we should continue to do that, but we know that at baseline, at least, people should get a CT scan. If somebody has risk for liver cancer, and there is a liver condition that has some association with scleroderma called PBC, there are particular recommendations for that subset of patients. People who have very severe esophageal disease, even though the risk of esophageal cancer may not be that great in our patients who have more reflux than the general population compared to other reflux populations, people probably should be getting endoscopies periodically if you're in that very severe, hard to control reflux population. And then if people have had specific drug exposures, like cyclophosphamide, might need bladder screening, for example. And other features. So if somebody has swallowing difficulty that's not explained by their scleroderma, yeah, we need to think about that. Or if somebody's losing weight, or they are anemic and we're not sure why, all those things might prompt us to do other things. And then we have kind of what it's called our now red flag patients. So somebody with newly diagnosed scleroderma who's RNA polymerase III positive. So I've shown you multiple times where we saw that that risk seems to be increased around the time that somebody develops scleroderma. If somebody's older at the age at which they develop scleroderma, don't ask me to define what older means. I'll just leave it vague. I had a fellow in my clinic the other day who described a patient to me who was 39 years old as middle-aged. And I said, okay, you realize that's younger than I am, right? So I won't define older because we don't really have a clear cutoff where we're thinking of older age. Men who develop scleroderma, or people who have aggressive disease, atypical presentations of disease, or unresponsive to treatment, like those are things to me that might mean that there might be a little more work to be done in terms of looking. And then obviously if somebody has something like profound weight loss, feverish chills, sweats, something else that might suggest cancer, or if there's a personal or very striking family history of cancer, then we think about that a little bit more. That's when we consider doing beyond age-appropriate screening kinds of studies, like CT scans of the chest, abdomen, and pelvis, tumor markers, potentially depending on what somebody's individual risk might look like, some blood tests if somebody's anemic, for example. Those are the kind of above and beyond tests that we might consider. But this is just based on the kind of epidemiologic data that I've shown you. We don't really have a good data set to say, oh, this is exactly how we should do it. So we don't know what's optimal at this point, because we certainly don't want to over-test and find things that are not meaningful. We want to kind of target our testing to the higher risk groups of patients to look for the kinds of cancers that we think might be increased in terms of risk. But as rheumatologists, and in particular rheumatologists who are taking care of scleroderma patients, like I feel like we need to take this on a little bit and educate the patients and educate their primary care providers how important it is to get cancer screening in an age-appropriate manner at least. And again, what the best screening strategy should be, we need to look at that more. So that's kind of our job on the research side, is to say, you know, how should we best do this? So how should we treat scleroderma in somebody who has cancer? Well, there are some treatments that are used for both, but this usually isn't kind of always the best option for either. So cyclophosphamide is a drug that we know might help in scleroderma for lung disease and maybe diffuse skin disease. And Cytoxan is technically a chemotherapy drug, and it is part of chemotherapy regimens for things like lymphoma. Stem cell transplant, there must have been a session this weekend about stem cell transplant, you know, which is used to treat some types of tumors as well. It's also a Cytoxan-based treatment regimen. The question is, and this is the trickier one, if somebody has cancer, should we avoid some immune-suppressing medicines that we might otherwise use to treat their scleroderma because of their cancer risk? So when we're suppressing the immune system with medicines, remember I told you your immune system helps you fight cancers. And so there's always this concern that if we suppress your immune system for your scleroderma, are we increasing your risk for cancer? And so this really has to be kind of an individualized discussion between your treating rheumatologist from the scleroderma standpoint and the doctor who's treating your cancer, because it's complicated and the risks are different with different drugs. So in terms of which drugs might be best to treat your scleroderma and which drugs might be best to treat your cancer. And then how we treat cancer in somebody with scleroderma is also something we contend with a fair amount and is not so easy either. So we have to worry a little bit about surgery, if surgery is going to go through affected skin in scleroderma, particularly if it's in the active phase. We worry a little bit about how that's going to heal. Chemotherapy, I told you sometimes some types of chemotherapy might worsen Raynaud's, and we have to kind of be aware of that if the patient's getting that kind of chemotherapy. And then radiation is a very difficult one, because radiation by itself, independent of scleroderma, can cause scarring both in skin and lung. So this is another situation where we can't quantitate probably the increased risk a patient with scleroderma might have, but we think there probably is some. So it again really depends on what kind of skin and lung disease the patient has to begin with from their scleroderma. If somebody has a lot of lung fibrosis and we are talking about radiating someplace that might hit the lungs in terms of the radiation, we might not want to take that risk. So just with everything in life, you know, there's going to be an optimal treatment for cancer. So we want our oncologists, if you didn't have scleroderma, like what would you tell this patient to treat? And then we decide, you know, are those potential side effects increased because you have scleroderma? And, you know, what's that risk-benefit ratio in terms of those side effects versus the optimal treatment for cancer? So to summarize, patients and doctors need to be aware of this risk. The magnitude of the risk is probably still small. Even when we talk about high-risk groups like RNA polymerase III, the majority of patients who make RNA polymerase III antibodies do not have cancer. Some scleroderma features may associate with higher risk in terms of the antibody that you make and the age at which you develop scleroderma. But we need to talk to all of our patients about kind of what's appropriate in terms of screening. And high-risk patients, based on their scleroderma, we think should be considered for additional screening for cancer. But we have to be mindful of the impact of treating scleroderma on cancer and vice versa. And that really, again, needs to be on an individual level with rheumatologists and oncologists and radiation oncologists and surgeons working together.